I have nothing to disclose. Obesity continues to be a growing nationwide epidemic. The number of bariatric surgeries done each year also continues to grow, with a growing proportion of those surgeries being the sleeve gastrectomy. In 2017, the sleeve gastrectomy accounted for 60% of all bariatric surgeries done that year. The most concerning pathology in bariatric surgical patients are any pre-existing neoplasms, a large hiatal hernia, esophagitis, and Barrett's esophagus, with 95% of experts considering Barrett's esophagus to be a major contraindication to the sleeve gastrectomy. The data regarding routine preoperative endoscopy is mostly retrospective in nature and is conflicting. This study is the largest study I could find in the literature. It looked at 626 patients, all underwent gastric bypass, was a prospective database retrospectively reviewed. Their most common findings were gastritis and esophagitis, but they did find one patient with gastric cancer and one patient with Barrett's, which I want to point out is a lot less than the estimated incidence of Barrett's of 5.6%. But given these findings, they did support routine preoperative endoscopy. This next study, also a fairly large study, looked at patients undergoing either gastric bypass or the sleeve gastrectomy, also retrospective review, and they found that the incidence of pathologic findings on endoscopy that affected management was very low yield and therefore did not support routine preoperative endoscopy. So per our guidelines co-sponsored by SAGES and ASGE, surgeons may perform preoperative endoscopy based on symptoms, but may need to have a lower threshold in those patients undergoing gastric bypass with the duodenal switch. So our research questions were, is there a difference in the incidence of pathologic findings between asymptomatic and symptomatic patients? And how often does routine preoperative endoscopy change management in bariatric surgical patients? This is given that many studies mostly just looked at the incidence of pathology, but not how it changed management. And we were specifically interested in those patients with reflux in the context of a growing sleeve gastrectomy practice nationwide. This was a retrospective chart review. Our study was a retrospective chart review performed between 2014 and 2016. We looked at all endoscopy reports in that time period and the associated preoperative clinic notes and operative reports. It was performed at a busy single-center bariatric practice. Our exclusion criteria included anybody who had previously undergone gastric surgery and anyone seeking a duodenal switch. Our practice philosophy is as follows. The gastric bypass is the gold standard bariatric operation in terms of weight loss outcomes and resolution of comorbidities. Esophagitis, particularly Barrett's esophagus, is a relative contraindication to the sleeve gastrectomy, and smoking, NSAID use, and steroid use are relative contraindications to the gastric bypass. We define change management as a change in the primary bariatric operation, such as changing from sleeve to bypass or bypass to sleeve, or adding on a separate procedure such as a hiatal hernia repair or a subtotal gastrectomy. We included 631 patients in our study, making our study the largest cohort of patients in this subject area. Most of the patients were female. The median age was 44, and the median BMI was 46. Most of our patients were asymptomatic, and in those patients who were symptomatic, the most common symptom was reflux. We found that there were a majority of the patients, both asymptomatic and symptomatic, had pathologic findings on endoscopy, and that 66% of those patients who were asymptomatic had a pathologic finding on endoscopy. Our most common findings on endoscopy were hiatal hernias and esophagitis. We had a 4.6% incidence of Barrett's esophagus, which is more consistent with the estimated incidence of Barrett's. 4 of our patients had a mass found on endoscopy, but only 1 was found to be malignant. Over 50% of the time, pathologic findings were found in asymptomatic patients. This could be related to the fact that the majority of our cohort was asymptomatic to begin with, but again emphasizes the fact that many of these lesions would have been missed in those practices that perform endoscopy only selectively. These are our numbers before and after endoscopy. As you can see, our practice tends to favor the gastric bypass. We did find an 18% overall change in management. 16% of those who initially planned to undergo gastric bypass had a change in management, and versus 22% of those who initially planned to undergo a sleeve gastrectomy. Most of the time, the change in management was a change in the primary operation or the addition of a hiatal hernia repair. A major limitation of our study is the fact that this is a retrospective study limited by documentation. Therefore, it was difficult to discern whether the change in management was specifically due to endoscopic findings or other patient factors. Therefore, we looked at our patients who were diagnosed with Barrett's esophagus on endoscopy because those patients would have had a change in management specifically due to the endoscopic finding of Barrett's. In those patients diagnosed with Barrett's, 9 had initially planned to undergo a sleeve, and 20 patients had initially planned to undergo a gastric bypass. And this is where we found the biggest change in management, with 67% of patients who initially wanted a sleeve having a change in management, with most of them being changed to a bypass. So we conclude the frequency of endoscopic findings appears to be independent of pre-endoscopy symptoms. There was a change in management in about 18% of patients after routine preoperative endoscopy, but again, difficult to tell whether it's specifically due to endoscopic findings or other patient factors. But we did find a change in management was higher in patients with biopsy-proven Barrett's, and we suspect that the effect of Barrett's esophagus may be more pronounced in predominantly sleeve practices. If ASMBS is saying that we did 134,000 sleeves in 2017, then in practices that perform only sleeve gastrectomies and don't do routine preoperative endoscopies, up to over 6,000 patients could have had Barrett's and perhaps should have been changed to a bypass. Therefore, we also conclude that selective screening in symptomatic patients may lead to misdiagnoses that should prompt consideration for changes in the planned bariatric surgical procedure. But given the biases of our practice favoring the gastric bypass, further study is necessary to see if our findings have broad applicability. The strengths of our study are that this is the largest cohort of bariatric surgical patients who underwent routine preoperative endoscopy. We evaluated patients undergoing either a gastric bypass or a sleeve gastrectomy. And we looked at the relationship between symptoms and pathologic findings as well as its effect on change in management. And our incidence of biopsy-proven Barrett's was consistent with the estimated incidence of 5.6% nationwide. Limitations of our study are that this is a retrospective review limited by documentation and any potential errors in diagnosis. And again, our practice is biased favoring the bypass, limits the generalizability of our study. These are my references. I'd like to thank the faculty at UT MIST, the Davis Clinic, our former fellow Jeannie Pan, and our medical students at DTO and Charlie. I'll take any questions.
Thank you, Dr. Chang.